afternoon, everybody. My name's Ros Morell. I'm the local project lead at Waikato Hospital for this collaborative. And when I was asked to present about teamwork, it gave me a really good opportunity to take a look at what we were doing and how we've got to this point. Our aim statement is really simple, but that doesn't mean to say it's simple to achieve, and everybody would understand the challenges that we face to move forward and to get some really positive work done. So there's endless information around effective teams and what it means and definitions. From my point of view, it sort of comes down to those three things: the cooperation, information sharing, learning and growth. And the challenges of getting a team together who are representing all the areas that we want represented within a large organisation where there are clinical demands and competing priorities. For me, probably the last thing, it's the biggest thing, is having that, it's luck, a huge measure of luck, who you get and who sits around the table. Our team was got together initially through expressions of interest. The pharmacy manager called together a meeting. And really, I was there by default because I work in quality and patient safety. I do have a clinical background. I've also got formal project methodology and had the good fortune to do the improvement advisor training. So this is quite neatly fitting in for me. Our team is constantly changing. And I think after these 2 days, we certainly need to tweak it again. We have the CMA as our sponsor. We have the good fortune of having John Barnard, who's national lead for medication safety, as part of our team. The CMO for training, so we've got a real good focus on the information that PGY1 and 2 doctors are given, registrar, pharmacist, and all the others you see on there. We don't have a consumer. We're aware of that gap being, not a good gap. We're working on it, I guess, is the best I can say to that. And we do engage our patients as often as we possibly can. I thought I probably should look at some literature and see how we were doing. And using Vice Board's 4 conditions, it was in one of our books from our IA training. I was reasonably happy to see that we're not doing too badly. The interdependence is, it's a really important issue to everybody on the team. There's some amazing skills and knowledge within the team that everybody brings a different view. That means that we're not complacent and we are constantly challenging each other. We've got great leadership. We've got John, we've got Tom Watson, we've got people who are in really influential positions. Everybody wants to be there. Nobody's had their arms twisted to be there. And that equal influence is, without a doubt, that ability to have everybody's input is just as important as the other. Of course, we have challenges. No team ever avoids challenges. One of the early things that happened was that there were some really conflicting expectations. We had a very good meeting early on where there was a lot of brainstorming and ideas, and like any area, there are huge desires to change the world and do it yesterday. And for a couple of people, they just couldn't get their heads around the frustration of bringing things right back down to small-scale testing and change. And as a reason, we lost certainly one person. And it was difficult because we had such passion and desire to make a difference. And you just want to harness that and bring it all together and really use it. But also, it's a reality check about what you can do. Having that consistent membership is tricky. You've got the rotation of junior docs and registrars and natural attrition, of course. But at the moment, we're reasonably stable. And assigning responsibilities, that's really tough. It's really tough when people have got huge demands on their time. And so we've found our own way at the moment, but again, after these couple of days, we're sort of changing ideas again. And the culture in a big organisation, how do you get everybody to agree? How do you get one or two people to agree? Everybody's special, everybody's got their own ideas. So that's a really, if anybody's got a magic bullet, for goodness sake, tell us. And here we are gone. What have I done? So because of I think that was the next one, yeah. Because of that challenge around assigning responsibilities in a big team, we've sort of got two teams on the go, and we're okay with that at the moment. We've got a small group, and after the last learning session, we realised we had to increase the frequency of meetings, but we also were realistic. We knew we couldn't get that big group together more often than once a month. So we have a small group. There are 4 of us and a couple of others, sort of when they can. And we've really done quite a lot of the nitty-gritty and the groundwork. So we've also got that frontline engagement, the staff on the floor, and that's very important to us. So we have more frequent meetings. We're informal and flexible. And the big group I see currently as being our advisor team. But that's going to change, I think. So what works for us? It's really having those influences at all levels. We've got the CMA, we've got John, who are well-respected professionals within our organisation, the clinicians dealing with clinicians. We obviously having the educators there and that broad range of people, the more disciplines we have, the more we can spread our fingers out into different areas. We're quite used to being transparent about what we do, about displaying information very publicly, not hiding anything. So being really visible and yes, just telling as many people as we can about what we're doing. Creating dissatisfaction with the current state, which is all around, what we're doing. It's not good enough. We're harming patients. We've got to do better than this. Just that constant trying to engage people to understand they can make a difference, and being prepared for the unexpected, and not worrying if it all turns into mayhem, because you'll actually learn an awful lot more from that mayhem than you will when it ticks along, a bit like our exercise this morning. How to be really tolerant and flexible. You walk into a ward and it's a nightmare. You use brains and walk out again. But keep going back and finding the right opportunity to engage people or do some work. And the last two are probably most important. It's choosing the right area. And the right area isn't the worst area, it's the best area. It's the area where you've got a can-do leader, where you've got someone who's going to engage their staff and hand over responsibility and tell them to find what works for them. That grassroots ownership. And it's that thing about you'll never make a change at the coalface unless you engage those people who work at the coalface. And for the underpinning factors for those last two things, I honestly believe go firmly back to the Releasing Time to Care programme that we have got in every single ward throughout our organisation. And that's over the last 5 years. And so it's become accepted that people in the grassroots have got the power, the ability and the knowledge to design what works for them. But more so, if they design what works for them, it's going to stay, because you don't want all the hard work you've just spent months and months doing disappearing the moment you turn your back. So using measurement has become a way of how they improve. Measurement is shown by safety crosses on the board, in the corridor, patients see it, public can see it. that translates into run charts. They can learn from mistakes. It's very public. You can see exactly where you are. And it's that utter belief that people on the floor staff have got a voice, and they can influence change. And that has been amazing to see where it's really worked. And engaging the wider team, it isn't just the nurses, the doctors. It's the multidisciplinary team. It's anybody who has any engagement within a ward. They're all just as valuable. So this is just an example of how it's on Colleen's ward, how the information is displayed. This is in the corridor. It's not the only thing they're working on. They've got discharge processes. They're looking at hand hygiene and all the information around the collaborative. The safety crosses, which are very obvious when things are working or not working. And Colleen also felt quite strongly that she needed the doctors engaged. And so put up that big new board in their office. All the information about the collaborative is right in front of their faces. They can see how they're doing. The run charts are there, the safety crosses are there, the background, the explanations, and the opportunity to get engaged and bring ideas to Colleen on the ward. And those people are so powerful. And lastly, just proof that we did let them in the ward. So thank you very much.